So the MYTHIC study was a phase I dose escalation and expansion study that looked at the PKMYT1 inhibitor Lunresertib, also known as Lunre, with or without combination agents, including Camonsertib, which is Camo, and that is an ATR inhibitor. The presentation that I discussed today was going over some of the efficacy data from the expansion cohorts in endometrial and ovarian cancer. As some context, Lunre is a first-in-class PKMYT1 inhibitor, and that is synthetically lethal in tumors harboring CCNE1 amplifications or deleterious mutations in FBXW7 or PPP2R1A. These are known as Lunre biomarkers. Lunre biomarkers are seen across many different solid tumor types, but are enriched in gynecologic cancers, including uterine and ovarian cancer. And these biomarker positive cases have a worse prognosis as compared to the biomarker negative gynecologic cancers, and that's been previously presented. The combination of Camo, an ATR inhibitor, synergizes with Lunre to enhance anti-tumor activity, and this combination has been looked at over different solid tumors and was previously presented, but what jumped out was that there were especially good signals of early efficacy in these gynecologic cancer patients. And so on the basis of that, we did backfill cohorts in ovarian and endometrial cancer. The study design is pretty straightforward. It's a standard phase I clinical trial. Module 2 was this combination. It enrolled patients that were 12 years of age and older who had these Lunre biomarker positive cancers, again, CCNE1 amplification, FBXW7 or PPP2R1A deleterious alterations, a good performance status of 0 to 1, adequate hematologic toxicity. And the primary endpoints were safety, tolerability, determination of a recommended phase II dose and schedule. So the major toxicity that's been seen with this combination has been anemia. And we looked at the risk factors for anemia and developed a mitigation strategy whereby patients who came in to the clinical trial with a hemoglobin of less than 11 were, instead of continuous dosing, put on a 2 weeks on, 1 week off schedule. And that really did help with the toxicity. So that is really the background. And then the data that I am presenting is on the efficacy of the gynecologic cohorts, in addition to an update on the safety of the overall group. So looking at the overall cohort of patients treated at the recommended phase II dose using the schedule optimization, there were 74 patients. The toxicities that we observed were predominantly low-grade and reversible toxicities. The most common grade 3 event was anemia followed by neutropenia, and about 5% of patients discontinued due to an adverse event. Looking at the efficacy population, there were 33 patients with endometrial cancer in the efficacy evaluable cohort. And this includes patients with high-risk endometrial histologies, including serous endometrial cancer, which was the most common, endometrioid, carcinosarcoma, clear cell. In ovarian, there were 32 patients in the efficacy evaluable cohort, both serous and non-serous. This group of patients was heavily pretreated with a median of 3 prior lines of therapy, and almost all of them had P53 mutations. If you look at the efficacy in these cohorts, the endometrial cancer patients had responses and clinical benefit across the different histologies. The RECIST confirmed and unconfirmed overall response rate was 24%, and the clinical benefit rate was 49%. In ovarian cancer, similarly, we saw efficacy across both serous and non-serous histologies. And again, this is in a heavily pretreated patient population. The RECIST confirmed and unconfirmed response rate was 31%, and the clinical benefit rate was 69%. So those are really the top line, results from the presentation.